Hey everyone, it's Christian here, former professor of anatomy and now osteopathic medical student. Today we're going to attempt to cover a high yield overview of step one and COMLEX acid base regulation, and we'll tie in some practice questions to help build your confidence. All right. So, what's the big idea? The big idea is to keep our bloodstream to have a pH between 7.35 to 7.45. And this physiological pH is important because, as you know, proteins can denature and we can cause systemic organ damage if we become too acidotic or too alkalotic. And there's also respiratory and ventilatory considerations as well. So, when we want to regulate our acids and bases, we have a couple of systems, three primary systems involved. And the first one are our buffers, and our buffers are rather our quickest way to balance our acids and bases. And then secondary to that is our lungs, and our lungs can regulate our pH within minutes, right? And then our long term, but our most effective one is our kidneys. Okay, so how do we do that, right? So our kidneys are going to regulate our pH by reabsorbing filtered bicarbonate, and we'll see that in just a moment at the proximal convoluted tubule. We'll also generate new bicarbonate there, as well as excrete hydrogen ions in that one-to-one ratio. And then we'll also see how the collecting duct, via its use of alpha intercalated cells and beta intercalated cells, help to fine-tune this pH as well. Okay, so a blast from the past here. You've probably have seen this equation multiple times, especially studying for the MCAT. But what we're essentially looking at is our Henderson-Hasselbalch equation and its and our use of Le Chatelier's principle, right? And so you'll see here our dynamic equilibrium between carbon dioxide, water, and our carbonic acid, and then our bicarbonate reserve. And the big idea here is that we're going to be in this dynamic equilibrium between respiratory acidosis, alkalosis, and metabolic acidosis and alkalosis. What do I mean by that? What I mean, and if we start here at the lungs, is that we treat carbon dioxide as acid. So that's what I want you to think about this as, right? CO2 is acid. Why? Because when CO2, and not just the CO2 we inhale, but also the CO2 we generate via cellular respiration, that turns into carbonic acid later on, right? So we treat it as a weak acid, essentially. So if I were to be hyperventilating, I'm exhaling and I'm getting rid of a lot of carbon dioxide, right? So I'm breathing out and I'm hyperventilating. Like let's say it's due to anxiety or something, right? I just took the renal exam and I'm hyperventilating and I'm exhaling a lot of CO2, right? What happens to my pH? Well, ultimately, I'm decreasing the amount of acid and I'm shifting more towards alkalosis, right? And then in the case of where I am hypoventilating, so let's say that I've really delayed respirations, such as in the case of a patient with opioid overdose, right? The respirations are significantly decreased. Their ventilation is significantly decreased because of respiratory compromise. What happens? They are trapping that carbon dioxide, and therefore the carbon dioxide accumulates and they become respiratorily acidotic. Okay. So we have some compensation that happens here at the level of the lungs, but also some long-term implications for the kidney as well. So how does the kidney mainly regulate acids and bases? It does so by the use of bicarbonate. Okay, so bicarbonate is our weak base, and it's going to help kind of rescue some of those protons that are there. And this is again, so since we're in dynamic equilibrium, Le Chatelier's principle applies here, right? Depending upon the addition or removal of a substrate will depend upon whether or not we're shifting more right or shifting more left. Okay, so this equation that we have here is our modified Henderson-Hasselbalch equation. As you know, the Henderson-Hasselbalch equation says that the pH of some type of solution in dynamic equilibrium is equal to the pKa plus the log base 10 of the concentration of our weak base over our weak acid. Now, we modified it here because, as you know, what are we mainly thinking about when we think about the acid that affects our pH? It's carbonic acid. It's not actually CO2, it's carbonic acid that does it directly. So, how we get this equation, if you care to know, right? And it's not super high yield to know where all of these pieces come from, but just for you to have a good idea, is that here we have our weak base, right? Which is the concentration of our bicarbonate ion, right? Times what we have, instead of putting here our weak acid, right? Instead of putting carbonic acid here, what we do is we take the solubility constant of carbon dioxide and we multiply it times the partial pressure of carbon dioxide, right? And so that's where we have this value here. 6.1 is just the pKa of carbonic acid, right? And so this is our modified Henderson-Hasselbalch equation. Don't get too overwhelmed with that just yet. We'll see how it's not actually as intimidating as it seems in just a moment. Okay, So before we can get into the actual regulation, I think we should provide a brief overview as to what level of each nephron segment is directly involved in this regulation. So let's move back here. Recall that when we think of bicarbonate, I want you to think of kidney acid-base balance. When we think of CO2, I want you to think of respiratory acid-base balance, okay? So because bicarbonate is a weak base, what do you think will happen if I have a patient that has acidosis because of the kidneys, right? I'll let you think about it. So if this patient has acidosis, it's because they have a lower level of bicarbonate, right? And so we call that metabolic acidosis. So when we think of low bicarbonate levels, which result in a low pH, right, we call that metabolic acidosis, right? If I have lots of bicarbonate coming from these kidneys, then I would call that metabolic alkalosis, all right? Now, if we go and take a look at the lungs, well, the reverse is going to be true because you see here that carbon dioxide is on the denominator here, right? And so carbon dioxide, what I want you to think about is that as we accumulate carbon dioxide, so as CO2 goes up, what happens to the pH? It goes down, right? If we make this number really, really big, the denominator really, really big, this value becomes really, really small. And that makes sense, right? As we said, if we accumulate a lot of carbon dioxide, right, we're becoming respiratorily acidotic. And if we blow off a lot of carbon dioxide, we exhale, such as in the case of hyperventilation, we become respiratorily alkalotic, right? Okay, and we'll see more about how we can manipulate this equation later on. So again, if I'm thinking kidneys, I'm thinking metabolic acidosis or alkalosis with a use of bicarbonate. And when I'm thinking lungs, I'm thinking of respiratory acidosis or alkalosis with regard to carbon dioxide, right? And remember, bicarb goes on top and carbon dioxide goes on the bottom. All right, so now we're looking at our bicarbonate reabsorption at the level of the proximal convoluted tubule. So is this metabolic or is this respiratory? It's metabolic. Okay, so let's orient ourselves with some structures here. And so this is going to be the tubular lumen. So this is the inside that lumen of the proximal convoluted tubule. This is going to be our epithelial cell, right? Our epithelial cell that's part of the PCT. And then we have our peritubular capillary. And so this is the capillary, so blood's running through here, and that's what's wrapping around the nephron segment, right? Okay, a couple other things we need to do to orient ourselves to what we're seeing here, just so that we're not confused. When we have the side that is facing the lumen, this is the apical side. This is the apical side of the epithelium. When we have the side that's going to hug the bloodstream, hug the capillary, that's going to be our basolateral side, right? So I think basolateral side faces the bloodstream, okay? The apical side is going to face the lumen of the proximal convoluted tubule or the lumen of the nephron, right? Okay, and it really is this epithelial cell that's doing a bunch of the main stuff to make things go back and forth. And recall our terminology here that it sounds a little bit counterintuitive, but once you really think about it, it makes more sense. When we are putting and pushing stuff back into the bloodstream, we call that reabsorption. And when we're pushing stuff back into, or not back into, but pushing stuff into the tubular lumen, that is secretion. Because what's happening here, whatever ends up here towards, once we get towards the collecting duct, that's going to be urine, right? And that's going to be excreted. So reabsorption is putting stuff back into the bloodstream, and secretion is putting stuff into the tubular lumen for it to later become secreted. And a lot of folks sometimes will confuse those two. Okay, what is going to power these transporters to do this stuff? The big thing here is going to be our sodium potassium ATPase. Our sodium potassium ATPase is at the basolateral side. And what's happening here is that we use ATP to pump out 3 sodium and to push in 2 potassium. Why do we do that? Okay. Well, this is a form of primary active transport. What happens is that if I keep pushing sodium out of this cell, what happens to the concentration of sodium inside the cell? Well, if I'm pushing a lot of sodium out of the cell, I'm creating a low intracellular sodium concentration. What does that mean? It means that this cell now wants sodium. So where am I going to get the sodium? I'm going to get the sodium from whatever's coming down through the lumen. So sodium is going to come here and rush into the cell. So this is our example of secondary active transport. This doesn't directly use ATP. This does on the basolateral side. So the basolateral side, sodium potassium ATPase, is going to create this extracellular gradient of, or rather intracellular gradient of sodium, right? I'm pushing lots of sodium out. So now the epithelial cell wants sodium. And so by doing so, it's going to power this transporter to bring in sodium from the lumen. Now, on this apical side here, this is an antiporter, right? It's a sodium hydrogen transporter. So what happens is that as I rush in this sodium here, because it wants to be in there because of the low intracellular sodium concentration, I'm also bringing protons out into the lumen. And that becomes really important here because they're being paired together. So as I push sodium inside the cell, it's also going to allow for protons to excrete out. Okay. Okay. So what's the big idea here? Where is this filtrate coming from, right? That's inside the tubular lumen here in the PCT. Well, this was actually the bicarbonate that was filtered at the level of the glomerulus. So remember that the glomerulus is the site of filtration. So whatever bicarbonate that was filtered at the level of the glomerulus is now here in the tubular lumen. Okay, this bicarb cannot pass the apical side. All right, that's something to note. Bicarbonate can't pass the apical side because it doesn't have a transporter to do it. It can pass via the basolateral side, but it can't pass via the apical side. And so what it needs to do is that this bicarbonate needs to turn into carbon dioxide because carbon dioxide is a small nonpolar molecule that can easily diffuse past a membrane, right? So how does it do that? Essentially, this carbonic acid needs to turn into, or rather, forgive me, this bicarbonate needs to turn into carbonic acid in order for it to break off into CO2 and H2O. How does it do that? It does that through the enzyme of carbonic anhydrase. So this is a super important enzyme, this carbonic anhydrase, because what happens is it takes this proton here that just came in and turns this bicarbonate into carbonic acid. And carbonic acid can now turn into water and carbon dioxide, which can freely flow inside the epithelial cell. Now, what's great about this is that carbon dioxide, or carbonic anhydrase, sorry, can go back and forth, which means that I can take this carbon dioxide and water and now turn it back into carbonic acid via the enzyme carbonic anhydrase. This now can deprotonate and split off into that proton that is recycled. And then any bicarbonate here can now leave via this transporter that I have here. And this is a co-transporter, right? The sodium that's going to leave here is going to take some of this bicarb here and now be reabsorbed into the bloodstream. And that's the basics of what happens for bicarbonate handling at the PCT level and how we reabsorb that 65% of bicarbonate at the level of the proximal convoluted tubule. Okay, so I know that was a lot of information. I promise you it's not as bad once we get into applying it to practice problems. Some other high-level overview is to think about not only does this happen at the PCT, we have some reabsorption and secretion of protons that happen at the thick ascending limb of the loop of Henle that happens here. The majority happens at the PCT, but there is some that happens here, right? And then the collecting duct has two cells that are important. We have alpha intercalated cells, which will secrete protons. And what are those protons going to do? It's going to correct acidosis by reabsorbing bicarbonate, and the reverse will happen for beta intercalated cells. Now, something to note here at the PCT, in addition to the bicarbonate handling, is that we'll also have some of these buffers that are here. So ammonium, and phosphate, which we call our titratable acid, are going to actually help to rescue some of those protons that are there and push them into the urine. So that's part of how we regulate. Now, this is more powerful, the use of phosphate than ammonium, but just know that these are working together in addition to the bicarbonate handling to deal with a lot of the acid-base regulation that's happening at the level of the PCT. Okay, so that's the physiology. Let's get into the math because the math can be intimidating. So what did we say before? We said that we had the pH, right, is equal to the pKa plus the log of the concentration of the weak base, which is our bicarbonate, over the concentration of our weak acid, or our conjugate base over our weak acid, right? And we said that we replaced the weak acid of carbonic acid, and we said we're just going to use carbon dioxide. Well, this is going to maintain constant. This is going to maintain constant, right? And this is proportional. So we can simply think of this conceptually as our pH is equal to some proportion of the concentration of our bicarb over this, our PCO2, okay? And this is going to really help us think about these problems and answering them pretty quickly. Now, when we look at our bicarb here, we said this was dealing with metabolic acidosis or alkalosis, right? When we look at our PCO2, we're thinking about respiratory acidosis or alkalosis, right? Okay, so what happens? Now let's play around with this equation. Just follow along with me for just a moment, okay? If I increase my level of my bicarb, what's that going to do to the pH? Well, it's a numerator. If I make the numerator really big, I'm going to make this number really big. And so as I increase the number of bicarb, I'm increasing my pH and making it more alkalotic. This makes sense, right? We know that as I put more weak base, we're going to become more basic, right? That should be intuitive, right? Now let's look at the bottom number here. If I increase my CO2, I make my denominator really big. And so what happens to my pH? Well, it goes down. And this makes sense. As I trap more CO2 inside my body, my pH becomes more acidotic. And so that is respiratory acidosis. And what we're essentially trying to see here is when a patient's serum pH level is acidotic or alkalotic, we want to think about, is this a metabolic issue? Is this a respiratory issue? Is it both? What's compensating, right? And we can find that actually pretty easily by doing an arterial blood gas or an ABG. And we'll look at that in just a moment. Okay, so I told you to memorize this. What I'd also like for you to memorize are two numbers here, which become really important. I want you to know that the bicarbonate level, the average bicarbonate level is 24. Yes, there's a range, but for our purposes, 24 is going to do us just beautifully, right? Okay, so just know that our average bicarbonate level, our normal bicarbonate level should be around 24. Our normal PiCO2 should be around 40. Okay, commit these to memory. Why? Because if I start to go below 40, if my PiCO2 is below 40, what does that mean? Think about that for a second. If my PiCO2 is below 40, that means I'm going to have respiratory acidosis or alkalosis. It's going to be respiratory alkalosis and therefore cause a decrease in pH. How about if I decrease, let's say it's below 24, my bicarb level is below 24. Well, I'm going to have, what happens if I decrease this number? I'm going to decrease this number. And so that's going to be metabolic acidosis. All right. And so use this as your threshold. Bicarb is 24, carbon dioxide is 40. Okay. So we know that once something happens the level of at the metabolic level or the respiratory level, right? Because pathologies can either trigger primarily a metabolic issue or a primary respiratory issue. There's going to be compensation, right? And so, for example, if I have a patient in metabolic acidosis, I might have respiratory alkalosis, and they can be competing to try to regulate the pH, right? Ultimately, the respiratory alkalosis is not going to fully flip over the pH, but it should be able to bring it a little bit closer to normal, but it's never going to fully fix it, right? Same thing is that if I have a patient that, let's say, again, they have opioid overdose, right? They have respiratory acidosis. I might see a compensatory metabolic alkalosis that tries to compensate for the pH level, but is never going to fully fix it. So how do I measure the expected compensation for a patient in metabolic acidosis? Well, I can use what's called Winter's formula, which tells me what the normal range is of PiCO2. And all that is I just take 1.5 and I multiply it by the known concentration of bicarbonate. I add 8, and then the range should be plus or minus 2. Okay. We'll see that in just a moment. It'll become more apparent once we do practice problems, right? Uh, and then an anion gap is something that we can calculate once we identify that a patient is in metabolic acidosis. So how are we going to tackle these problems? The first thing we're going to do is we're going to assess what's the pH, the serum pH level. If it's below 7.35, the patient is acidotic. If it's greater than 7.45, it's alkalotic. Now we need to identify, is this metabolic or respiratory, right? And so we're going to use our threshold here of 24 over 40, right? Taking a look at bicarb over PiCO2. And then identify what's the primary driving issue here. Is it going to be metabolic? Is it going to be respiratory? Is there compensation that happens? If there's metabolic acidosis, I would want to calculate an anion gap. I might also calculate Winter's formula to see if the compensation is appropriate. And then we're going to identify what the pathology is. Okay, seems like a lot of steps. I promise you it's not that bad. We're going to go through these together. I'm right there with you. Okay, so we get a problem like this. What is the primary disorder? First thing I'm going to do is I'm going to look at the serum pH level, and it's 7.54. Well, what do we know about the normal pH level? It's supposed to be 7.35 to 7.45, right? Well, so this patient is alkalotic. I don't know yet if it's respiratory or metabolic based, but I know that they're alkalotic. It's higher than it should be. Now I look at the bicarb level. Well, what was my normal bicarb level? I said should be 24. Okay. This level here is 20. So I have a low bicarb level, which is the top number, right? If I have a low bicarb level, am I going to be metabolically acidotic or alkalotic? I'm going to be metabolically acidotic. Okay. So this here says metabolic acidosis. Okay. But let's take a look at this here, our PiCO2 level. What was our normal PiCO2 level? It was 40. Well, this number is lower than 40. And so this tells me this is respiratory acidosis or alkalosis. This would be respiratory alkalosis. Okay. So because I'm having less CO2, right? Less CO2, right? And so that's going to shift me towards being more basic. So what did I say here? The patient is overall is basic, right? Their blood is basic overall. Their bicarb level suggests that they're metabolically acidotic, right? Their PiCO2 level tells me that they're respiratorily alkalotic. Well, which one matches what their real pH is? Their PiCO2 or their bicarb? It's going to be their PiCO2, right? And so this tells me that what is their primary disorder? Their primary disorder is B, respiratory alkalosis. So what's going on with this metabolic acidosis that's happening here? Well, this is actually, now we've identified, this is the compensatory mechanism that's kicking in to try to bring our pH back to where it should be. Okay, let's do another one. A 66-year-old woman with COPD presents to the ED with somnolence. Okay. Her arterial blood gas shows the following. A pH is 7.25, bicarb is 34, PiCO2 is 79. Okay, let's take a look at this. The pH is 7.25, which tells me that overall they are acidotic. Okay. Their bicarb level, our normal bicarb level should be 24. What is this? It's higher than 24, so they're metabolically alkalotic. Okay. How's their PiCO2? Well, PiCO2 should be 40, and this is way above 40. It's almost twice 40. So this patient is respiratorily acidotic. So I have patient overall is acidotic. They are metabolically alkalotic, but respiratorily acidotic. So what does that tell me? Our answer is C. They have respiratory acidosis and they have compensatory metabolic alkalosis. This is kicking in to try to fix the issue that's happening at this level. Okay, let's do another one. Does the PiCO2 in the case below fall within the expected range of respiratory compensation? So the patient is acidotic. Their bicarb, well, it's 14, normal is 24. So this tells me that they're metabolically acidotic, right? And then their PiCO2 is 34, which tells me that they are respiratorily acidotic as well, right? So I have a metabolic acidosis and I have, oh, forgive me. I have a metabolic acidosis and I have respiratory alkalosis, respiratory alkalosis, right? This is our compensatory mechanism. Okay, how to identify whether or not this is sufficient respiratory compensation? Well, if we go back a few slides, we said that we can use Winter's formula, which says that our expected PiCO2 for compensation is equal to 1.5 times the bicarb level plus 8 plus or minus 2. So let's take a look at this. Our bicarb level is 14, right? So I'm going to do 14. I'm going to multiply that by 1.5, right? That's going to give me 21. And then I'm going to add 8 to that, and that's 29. Okay, so now I want to do plus or minus 2. So I should be, what's that? What's plus or minus 2? Well, 29 plus 2, 29, 30, 31. The lower range is going to be 29, 28, 27. So my expected range should be 27 through 31. Is this PiCO2 within 27 through 31? No, right? And so this is not falling within the expected range for respiratory compensation. Okay, cool. Now we know how to tackle the beginning parts of acidosis, alkalosis, identifying if it's metabolic, if it's respiratory, and whether or not there's appropriate compensation using Winter's formula. Well, now we need to understand a few things about what happens when a patient specifically is in metabolic acidosis, because there are some implications here. For a patient in metabolic acidosis, we need to identify whether or not this is a normal anion gap acidosis or if this is a high anion gap acidosis. Well, what does that mean? What this means is that what I do is to calculate an anion gap is I take sodium and I'm going to subtract bicarbon chloride. And that's going to tell me what our level of our ions are, what this anion gap here. It's going to help us identify what this is. All I'm doing is I'm taking the sodium concentration, subtracting bicarb, subtracting chloride ions. And whatever is here is going to tell me what our organic anions are. And this helps identify or helps us kind of develop a clinical index of suspicion for what our pathology could be, because those anions, those organic anions, are going to secrete protons, and those protons can decrease bicarb levels. Okay, so when I have a patient that has metabolic acidosis, I need to calculate the anion gap because the anion gap can help give us insight into what some of the possible pathologies are. If I have a high anion gap, that means that those organic anions are secreting protons and taking up some of that bicarb. So that can give me some clinical insight in terms of what am I actually dealing with, what's causing this metabolic acidosis. The key concept here is for a patient in high anion gap metabolic acidosis, we have an addition of an acid rather than loss of bicarb. Whereas in a patient that has normal anion gap metabolic acidosis, the issue is loss of bicarb, right? That loss of bicarb is replaced by chloride because when we lose bicarb, what's that? That's a negatively charged anion, right? We need chloride that's negatively charged to maintain that electron neutrality. Okay. So in this case, we might call this hyperchloremic metabolic acidosis. This is actually common for patients that have severe diarrhea because they're losing a lot of bicarb that's there, right? Okay, so let's calculate an anion gap. So we said you can calculate an anion gap by doing sodium minus bicarb minus chloride, SBC, sodium minus bicarb minus chloride. There's different equations to calculate this. This is the one that I think is the most easy to memorize. So I'm going to do 140 sodium minus bicarb, so minus 16, minus chloride, minus 114. Okay, and that gives me 10. So our anion gap is B, 10, right? What did we say the normal anion gap was? It should be between 8 to 12. All right, so this falls between that. And so this patient would have a normal anion gap metabolic acidosis or NAGMA, right? Okay. Now, another thing to consider about metabolic acidosis is that we can have some weird stuff go on with potassium. Why? Well, because in the case of metabolic acidosis, which we're seeing here, right, what happens? The secretion of protons, right, are increased. There's the protons are increased in the extracellular fluid. These are going to rush into the cell. Protons rush into the cell in our intracellular fluid. Well, the problem here is that remember that the cell wants to maintain electron neutrality, and our proton is positively charged. So as I pump protons inside of the cell, to compensate for that, I'm pushing potassium out of the cell. Well, where's out of the cell? That's the bloodstream. So for these patients in metabolic acidosis, right, what can happen here is as I increase in these protons, I'm flooding potassium out into the bloodstream, and that's going to cause the patient to have hyperkalemia, which can be very dangerous. It can have cardiac implications, right? You might notice a practice problem which says that that patient's ECG shows peak T waves, right? Which is an indication of hyperkalemia, right? Or they can enter into a very serious cardiac arrhythmia called torsades de pointe, or polymorphic ventricular tachycardia. They can go into cardiac arrest because of hyperkalemia. That's one of the major dangers of metabolic acidosis, right? So just note that in cases of metabolic acidosis, you can have relative hyperkalemia as a complication because of a bunch of these protons rushing inside the cell. Therefore, we're going to have a major efflux of potassium into the bloodstream, which raises the potassium levels and can cause downstream cardiac arrhythmias. Okay, the opposite is true here, right? If the reverse is true and I flood an influx of potassium inside the cell, I can have less potassium in the bloodstream and cause a relative hypokalemia. Now, note that there are some special considerations here. This is most likely to happen in cases of what we call mineral or non-organic acidosis. So this is most common in cases like renal tubular acidosis, uremia, which is advanced renal failure, or commonly, and what I've seen in practice problems, is the use of acetazolamide, which is a carbonic anhydrase inhibitor, right? We know that, right? We know carbonic anhydrase is seen in the level of the PCT, right? Okay. And so this is more pronounced, right, in the case of, in these cases, the mineral acidosis. Now, in lactic acid acidosis, or in a patient that has diabetic ketoacidosis, we might not see this issue, right? We can actually see normal potassium levels. And the reason why has to do with their protons, right? The acid itself actually enters the cell. So we don't need that proton H plus exchanger that happens here. So the big takeaway here is that for patients in lactic acidosis or ketoacidosis, diabetic ketoacidosis, you might see normal potassium levels even if they have a metabolic acidosis. Okay, let's see this. Let's do practice problems. Which situation most classically causes a normal anion gap? Hyperchloremic metabolic acidosis. I'll let you take a second to answer this. Okay, and the answer here is D, severe diarrhea. This is a classic case.
Let's do another problem. The arterial blood gas shows that patient's pH is 7.25, so we are acidotic. Our PCO2 is 50, right? And so that is higher than our 40, so we're seeing here this patient has respiratory acidosis. And our bicarb is 21, okay? So the patient's bicarb is 21, which tells us that we have, because it's supposed to be 24, right, we have a metabolic acidosis as well. This patient has metabolic acidosis. All right, we saw it. Winter's formula predicts expected PCO2 range around 39 to 43. What does the actual PCO2 of 50 indicate? Well, our PCO2 here is 50, which is way out of this expected range of compensation. So what does that tell us? Well, this tells us that this is not normal compensation. In fact, this is actually concurrent respiratory acidosis, right? That's what's going on here. Because it is out of our bounds of our Winter's formula, right? We know that this is not a compensatory mechanism here. It's actually the patient has both metabolic acidosis and respiratory acidosis. How did we figure that out? We use Winter's formula to calculate that. What is the most likely acid-base disturbance in the patient? The respiratory rate of 6 reps per minute due to opioid overdose. Okay, so if I have a patient that has decreased ventilation, they have a decreased ventilatory rate, right? What's happening is that they are trapping that carbon dioxide. If I trap that carbon dioxide, it accumulates, and therefore that patient has C, respiratory acidosis. And they might have a metabolic alkalosis that begins to compensate. Okay, what is the primary disorder for a patient with a pH of 7.54? So that's alkalotic. The bicarb is 20, so that is metabolically acidotic. And our PCO2 is 24, which means that is way lower than our 40, so that's a respiratory alkalosis. If I have respiratory alkalosis but a metabolic acidosis, which one's winning here? Which one meets the actual case of alkalosis, right? Well, it would be the respiratory situation, right? And so this patient here has B, respiratory alkalosis. All right, that's pretty much it, guys. I hope this provides some foundation into continued study. If you need any more support, please feel free to reach out.